Good day! I am Hannah Jamaica Delfin together with my partner,
Patricia Marie Delgado,
and today,
we are going to discuss
the respiratory tract drugs. Today, we are going to tackle first the introduction of respiratory tract drugs, the drugs for asthma and chronic obstructive pulmonary disease, which falls into two principles, which are the anti-inflammatory drugs and the bronchodilators. And lastly, drugs for allergic rhinitis, cough, and colds. But before that, let's define first what is respiratory system. The respiratory system is the network of organs and tissues that helps you breathe. It includes your airways, lungs, and blood vessels. The muscles that power your lungs are also part of the respiratory system. These parts work together to move oxygen throughout the body and clean out waste gases like carbon dioxide. These are the parts. First is the nose, the mouth, throat or pharynx, voice box or larynx, windpipe or the trachea, large airways or bronchi, small airways or the bronchioles, and the lungs. The upper respiratory tract is made up of the nose, nasal cavity, sinuses, larynx, and the trachea, while the lower respiratory tract is made up of the lungs, bronchi, and bronchioles. Air sacs are the alveoli. So what is respiratory tract drugs? These are the drugs used to treat respiratory conditions. It falls into several categories: cough suppressants, bronchodilators, expectorants, and decongestants. Antibiotics and anti-inflammatory drugs are also important in the treatment of many respiratory diseases. So what are the types of respiratory tract diseases? To be discussed by Ms. Delgado.
first is asthma. Asthma is a chronic inflammatory disease characterized by inflammation of the airways, bronchial hyperactivity, and bronchospasm. Allergy is often the underlying cause. The second is chronic obstructive pulmonary disease, or COPD, refers to a group of diseases that cause airflow blockage and breathing-related problems. It includes emphysema and chronic bronchitis. COPD makes breathing difficult for the 16 million Americans who have this disease. What are the drugs for asthma and COPD? The major drugs for asthma and COPD fall into two main pharmacologic classes: the anti-inflammatory agents and bronchodilators. The principal of anti-inflammatory drugs are the glucocorticoids. The principal of bronchodilators are the beta-2 agonists. For chronic asthma and stable COPD, glucocorticoids are administered on a fixed schedule, almost always by inhalation. Beta-2 agonists may be administered on a fixed schedule or for long-term control, or PRN, or to manage an acute attack. Like the glucocorticoids, beta-2 agonists are usually inhaled. These are the overview of major drugs for asthma and chronic obstructive pulmonary disease. Anti-inflammatory drugs, especially inhaled glucocorticoids, are the foundation of asthma and COPD therapy. These drugs are taken daily for long-term control. Most people with asthma require these drugs for management at some point. What are the anti-inflammatory drugs? First, glucocorticoids, leukotriene modifiers, cromolyn, omalizumab or Xolair, and roflumilast. First is glucocorticoids. Glucocorticoids like budesonide and fluticasone are the most effective drugs available for long-term control of airway inflammation. Administration is usually by inhalation, but may also be IV or oral. Adverse reaction to inhaled glucocorticoids are generally minor, as are reactions to systemic glucocorticoids taken acutely. Mechanism of anti-asthma action. Glucocorticoids reduce asthma symptoms by suppressing inflammation. Specific anti-inflammatory effects include decreased synthesis and release of inflammation mediators. For example, leukotrienes, histamine, and prostaglandins. Decreased infiltration and activity of inflammatory cells like eosinophils and leukocytes. Decreased edema of the airway mucosa, secondary to a decrease in vascular permeability. Adverse effects. Inhaled glucocorticoids. These preparations are largely devoid of serious toxicity, even when used in high doses. The most serious concern is adrenal suppression. The common adverse effects are oropharyngeal candidiasis and dysphonia, hoarseness, speaking difficulty. Both effects result from local deposition of inhaled glucocorticoids. For oral glucocorticoids, when used acutely or less than 10 days, even in very high doses, oral glucocorticoids do not cause significant adverse effects. However, prolonged therapy, even in moderate doses, can be hazardous. Preparations, dosage, and administration. Inhaled glucocorticoids. 6 glucocorticoids are available for inhalation. 4 are available in MDIs, 3 are available in DPIs, and 1 is available in suspensions for nebulizations. Inhaled glucocorticoids are administered on a regular schedule, not PRN. Pediatric and adult dosage are regular schedule, not PRN. The dosage should not keep as low as possible to minimize adrenal suppression, possible bone loss, and other adverse effects. Next is leukotriene modifiers. Leukotriene modifiers suppress the effects of leukotrienes, which are compounds that promote smooth muscle constriction, blood vessel permeability, and inflammatory responses through direct action as well as through recruitment of eosinophils and other inflammatory cells. In patients with asthma, these drugs can decrease bronchoconstriction and inflammatory responses such as edema and mucus secretion. The 3 leukotriene modifiers are currently available: the Xeluton, the Zaferlucast, and Montelukast. Xeluton, an inhibitor of leukotriene synthesis, is approved for asthma prophylaxis and maintenance therapy in adults and children 12 years and older. Symptomatic improvement can be seen within 1 to 2 hours of dosing. Mechanism of action. Benefits derived from inhibiting 5-lipoxygenase, the enzyme that converts arachidonic acid into leukotrienes. This decreases the amount of leukotrienes available to induce inflammation. Adverse effects. Xeluton can injure the liver, as evidenced by increased plasma levels of alanine aminotransferase activity. A few patients have developed symptomatic hepatitis, which reversed after drug withdrawal. To reduce the risk of serious liver injury, ALT activity should be monitored. The recommended schedule is once a month for 3 months, then every 2 to 3 months for the remainder of the first year, and periodically thereafter. Next is Zaferlucast. Zaferlucast was the first representative of a unique group of anti-inflammatory agents, the leukotriene receptor antagonist. The drug is approved for maintenance therapy of chronic asthma in adults and children 5 years and older. The mechanism of action. Benefits derive in part from reduced infiltration of inflammatory cells, resulting a decreased bronchoconstriction. Adverse effects. The most common side effects of Zafirlukast are headache and gastrointestinal disturbances, both of which are infrequent. Arthralgia and myalgia may also occur. Like Zelyuton, Zafirlukast can cause depression, suicidal thinking, hallucinations, and other neuropsychiatric effects. A few patients have developed Churg-Strauss syndrome, a potentially fatal disorder characterized by weight loss, flu-like symptoms, and pulmonary vasculitis or blood vessels inflammation. Then we have Montelukast. Montelukast, a leukotriene receptor blocker, is the most commonly used and leukotriene modulator. The drug has 3 approved indications. First is prophylaxis and maintenance therapy of asthma in patients at least 1 year old, and prevention of exercise-induced bronchospasm in patients at least 15 years old, and relief of allergic rhinitis. Mechanism of action. Montelukast has a highly affinity for leukotriene receptors in the airway and on pro-inflammatory cells such as eosinophils. By occupying these receptors, the drug blocks receptor activation by the body's leukotrienes. Adverse effects. Montelukast is generally well tolerated. In clinical trials, adverse effects were equivalent to those of placebo. In contrast to Zelyuton and Zafirlukast, Montelukast does not seem to cause liver injury. As with Zafirlukast, Churg-Strauss syndrome has occurred when glucocorticoids dosage were reduced. Post-marketing reports suggest a link between Montelukast and neuropsychiatric effects, especially mood changes and suicidality. Fortunately, these effects are rare. The next anti-inflammatory drugs is cromolyn. Cromolyn is an inhalational agent that suppresses bronchial inflammation. This drug is used for prophylaxis, not quick relief in patients with mild to moderate asthma. Anti-inflammatory effects are less than with glucocorticoids. Therefore, cromolyn is not a preferred drug for asthma therapy. When glucocorticoids create problems, however, cromolyn may be prescribed as alternative therapy. Mechanism of action. Cromolyn suppresses inflammation. It does not cause bronchodilation. The drug acts in part by stabilizing the cytoplasmic membrane of mast cell, preventing release of histamine and other mediators. In addition, cromolyn inhibits eosinophils, macrophage, and other inflammatory cells. Adverse effects. Cromolyn is the safest of all anti-asthma medications. Significant adverse effects occur in fewer than 1 of every 10,000 patients. Occasionally, cough or bronchospasm occurs in response to cromolyn inhalation. Preparations, dosage, and administration. Cromolyn is administered using a power-driven nebulizer. The initial dosage for adults and children is 20 mg 4 times a day. For maintenance therapy, the lowest effective dosage should be established. Next is omalizumab or Xolair. Omalizumab or Xolair is a monoclonal antibody with a unique mechanism of action. Antagonism of IgE, a type of antibody. The drug is a second-line agent indicated only for allergy-related asthma and only when preferred options have failed. Omalizumab offers modest benefits and has significant drawbacks. Mechanism of action. Omalizumab forms complexes with free IgE in the blood and thereby reduces the amount of IgE available to bind with its receptors on mast cell. This greatly reduces the number of IgE molecules on the mast cell surface and thus limits the ability of allergens to trigger relaxes of histamine, leukotrienes, and other mediators that promote bronchospasm and airway inflammation. Adverse effects. Omalizumab can cause a variety of adverse effects. The most common are injection site reactions, viral infection, upper respiratory infection, sinusitis, headache, and pharyngitis. Early clinical trials suggested a very small risk of cardiovascular problems and malignancy. A meta-analysis of post-marketing studies revealed no significant increase in cardiovascular events between subjects taking omalizumab and a placebo. There are small increase in rare malignancy occurrence in subjects taking omalizumab. However, a clear relationship to the drug has not been established. Possible adverse consequences of long-term IgE suppression are unknown. Preparations, dosage, and administration. Omalizumab or Xolair is available as a powder, 202.5 mg in single-use vials for reconstitution with 1.4 ml of sterile water. Dissolving the powder, which can take 20 minutes or longer, yields a final solution of 150 mg per 1.2 ml. Administration is by sub-Q injection, which may take 5 to 10 seconds because the solution is somewhat viscous. The reconstituted solution should not use within 4 hours if stored at room temperature, or within 8 hours if stored cold. Omalizumab powder should be kept refrigerated. The next is roflumilast. The mechanism of action. Roflumilast is a phosphodiesterase type 4 or PDE4 inhibitor. The PDE4 is an enzyme that breaks down cyclic adenosine monophosphate or CAMP. The end result of this process is an increase in inflammatory mediators. By inhibiting the enzyme, roflumilast decreases the release of inflammatory products. This helps to prevent inflammation and decrease damage to lung tissue, thereby improving pulmonary function. Adverse effects. Psychiatric adverse effects are the most concerning. About 6% of those in clinical trials report events ranging from anxiety and depression to suicidal behavior. For this reason, it is not recommended for patients with a history of depression. Loss of appetite frequent occurs. Weight loss is common. 20% of patients in clinical trials lost between 5% and 10% of their pre-treatment weight. Other adverse effects include GI complaints like nausea and diarrhea, insomnia, and headache. There have been adverse events in animal reproduction studies. so this is not recommended for pregnant women. Preparations, dosage, and administration. Roflumilast is supplied as tablets containing 500 mcg of drugs. Dosage is 1 500 mcg tablet daily. It may be taken with or without food. The second pharmacologic class is bronchodilators. Bronchodilators provide symptomatic relief in patients' asthma and COPD but do not alter the underlying inflammation that is part of the disease process. Accordingly, most patients who require a bronchodilator also use an inhaled glucocorticoid for long-term suppression of inflammation. Monotherapy with a bronchodilator is appropriate only when asthma is very mild and attacks are infrequent. Bronchodilators include beta-2 adrenergic agonists, methylxanthines, anticholinergic drug, glucocorticoid long-acting beta agonist combinations, and beta-adrenergic agonist anticholinergic combinations.
First is beta-2 adrenergic agonist. Inhaled beta-2 agonists are the most effective drugs available for relieving acute bronchospasm and preventing EIT. Virtually all patients with asthma use these first-line drugs as a component of an asthma management regimen. Mechanism of action. The beta-2 agonists are sympathomimetic drugs that activate beta-2 adrenergic receptors. By activating beta-2 receptors in smooth muscles of the lung, these drugs promote bronchodilation and thus relieve bronchospasm. In addition, beta-2 agonists have a limited role in suppressing histamine release in the lung and increasing ciliary motility. Classification by route and time course. Beta-2 agonists may be administered orally or by inhalation, and their effects may be brief or prolonged. All of the oral agents are long-acting. Among the inhaled agents, some are short-acting and some are long-acting. With the short-acting inhaled preparations, effects begin almost immediately, peak in 30 to 60 minutes, and persist for 3 to 5 hours. Because of this time course, the short-acting beta-2 agonist can be used to abort an ongoing attack, but cannot be used for prolonged prophylaxis. With the inhaled long-acting beta-2 agonist, onset depends on the drugs. With formoterol and formoterol, onset is relatively rapid, whereas onset is delayed with salmeterol. However, because these drugs are used on a fixed schedule for long-term control, the difference in onset is not very important. Short-acting beta-2 agonists are often life-saving medications. If they are taken in excess, however, overdose can lead to dangerous adverse effects, such as tachydysrhythmias, angina, and seizures. Cardiac arrest and death may occur. Next is methylxanthines. Methylxanthines have a number of pharmacologic actions that give them therapeutic value. They relax smooth muscles, including those of the bronchi, esophagus, and gastroesophageal sphincter. They are central nervous system stimulants that can reduce fatigue and improve concentration. Next is anticholinergic drug. Anticholinergic drugs improve lung function by blocking muscarinic receptors in the bronchi, reducing bronchoconstriction. Two agents are available, ipratropium and tiotropium. These drugs are approved only for COPD but are used off-label for asthma. Both drugs are administered by inhalation. Glucocorticoid and long-acting beta-2 agonist combinations provide the anti-inflammatory benefits of the glucocorticoid and the bronchodilation benefits of the beta-2 agonist. These combinations are more convenient than taking a glucocorticoid and long-acting beta-2 agonist separately, but have the disadvantage of restricting dosage flexibility. These products are not recommended for initial therapy. Rather, they should be reserved for patients whose asthma has not been adequately controlled with an inhaled glucocorticoid alone. All three products carry a black box warning about possible increased risk for asthma severity or asthma-related death from the long-acting beta-2 agonist in the combination. However, because the long-acting beta-2 agonist is combined with a glucocorticoid, risk should be minimal. Lastly is the beta-2 adrenergic agonist anticholinergic combinations. The combination of a beta-2 agonist with a cholinergic antagonist optimizes bronchodilation by capitalizing on the unique action of the individual agents. As mentioned previously, beta-2 agonists promote bronchodilation by stimulating adrenergic receptors. In the lungs, this relaxes smooth muscles in the airways. Cholinergic antagonist promotes bronchodilation by blocking cholinergic receptors. This relaxes smooth muscles tone by preventing stimulation of cholinergic receptors. Additionally, beta-2 agonists primarily affect the bronchioles, whereas anticholinergics primarily affect the bronchi. This action in different areas of the airways further enhances bronchodilation. So now let's move on to our next topic, the drugs for allergic rhinitis, cough, and colds. But let's define first what is allergic rhinitis. Allergic rhinitis is an inflammatory disorder that affects the upper airway. Major symptoms are sneezing, rhinorrhea or runny nose, pruritus or itching, and nasal congestions caused by dilation and increased permeability of nasal blood vessels. In addition, some patients experience associated conjunctivitis, sinusitis, and even asthma. Allergic rhinitis has two major forms, seasonal and perennial. Seasonal rhinitis, also known as hay fever, occurs in the spring and fall in reaction to outdoor allergens such as fungi and pollens from weeds, grasses, and trees. Perennial or non-seasonal rhinitis is triggered by indoor allergens, especially the house, dust mite, and pet dander. So what are the drugs for allergic rhinitis? The first is glucocorticoids, antihistamines, cromolyn, sympathomimetics, anticholinergics, and antileukotrienes. Intranasal glucocorticoids are the most effective drugs for the prevention and treatment of seasonal and perennial rhinitis. Because of their anti-inflammatory actions, these drugs can prevent or suppress the major symptoms of allergic rhinitis, the congestion, rhinorrhea, sneezing, nasal itching, and erythema. Adverse effects of intranasal glucocorticoids are generally mild. The most common are drying of the nasal mucosa and a burning or itching sensation. Sore throat, epistaxis or nosebleed, and headache may also occur. Next is oral antihistamine. Oral antihistamine are first-line drugs for mild to moderate allergic rhinitis. For therapy of allergic rhinitis, antihistamine are most effective when taken prophylactically and less helpful when taken after symptoms appear. Actions and uses. These drugs can relieve sneezing, rhinorrhea, and nasal itching. However, they do not reduce nasal congestion because histamine is only one of several mediators of allergic rhinitis. Antihistamine are less effective than glucocorticoids. Antihistamine should be administered on a regular basis throughout the allergy season even when symptoms are absent to prevent initial histamine receptor activation. Adverse effects are usually mild. The most frequent complaint is sedation, which occurs frequently with the first-generation antihistamine, and much less often with the second-generation agents. Accordingly, second-generation agents are clearly preferred for students who need to remain alert in class and for patients who do work that requires alertness. Anticholinergic effects, example drying of nasal secretions, dry mouth, constipation, urinary hesitancy are common with first-generation agents and relatively rare with the second-generation agents. Next is intranasal cromolyn. Actions and uses. For the treatment of allergic rhinitis, intranasal cromolyn is extremely safe, but only moderately effective. Benefits are much less than those of intranasal glucocorticoids. Cromolyn reduces symptoms by suppressing the release of histamine and other inflammatory mediators from mast cells. Accordingly, the drug is best suited for prophylaxis and hence should be given before symptoms start. Responses may take 1 or 2 weeks to develop. Patients should be informed of this delay. Adverse reactions are less than with any other drug for allergic rhinitis. Next is sympathomimetics or decongestant. Actions and uses. Sympathomimetics, example, phenylephrine, pseudoephedrine, reduce nasal congestion by activating alpha-1 adrenergic receptors on nasal blood vessels. This causes vasoconstriction, which in turn causes shrinkage of swollen membranes, followed by nasal drainage. With topical administration, vasoconstriction is both rapid and intense. With oral administration, responses are delayed, moderate, and prolonged. Adverse effect: rebound congestion. Develops when topical agents are used more than a few days. With prolonged use, as the effects of each application wear off, congestion becomes progressively worse. To overcome this rebound congestion, the patient must use progressively larger and more frequent doses. Other adverse effect is central nervous system stimulation. It is the most common adverse effect of the oral sympathomimetics. Symptoms include restlessness, irritability, anxiety, and insomnia. These responses are uncommon with topical agents with use as recommended. Next is the cardiovascular effects. By activating alpha-1 adrenergic receptors on systemic blood vessels, sympathomimetics can cause widespread vasoconstriction. Generalized vasoconstriction is most likely with oral agents. However, if used in excess, even the topical agents can cause significant systemic vasoconstriction. Other adverse effect is abuse. Pseudoephedrine is associated with abuse. By causing CNS stimulation, the sympathomimetic can produce subjective effects similar to those of amphetamine. Also, it can be readily converted to methamphetamine, a widely used drug of abuse. Next is the anticholinergic. Actions: block nasal cholinergic receptors and thereby reduce secretions. Do not decrease sneezing, nasal congestion, or postnasal drip. The adverse effect: nasal drying and irritation. Lastly, anti-leukotrienes. The action: block leukotriene receptors and thereby reduce nasal congestion. The adverse effect: rare neuropsychiatric effects. Next is cough. Let's define what is cough. It is a complex reflex involving the CNS, the peripheral nervous system, and the muscles of respiration. The cough reflex can be initiated by irritation of the bronchial mucosa as well as by stimuli arising at site distant from the respiratory tract. Cough is often beneficial, serving to remove foreign matter and excess secretions from the bronchial tree. The productive cough that is characteristic of chronic lung disease, example emphysema, asthma, bronchitis, should not be suppressed. For example, not all coughs, however, are useful. When a cough is non-productive, creates discomfort, or deprives a patient of comfort or sleep, cough suppressant medication is appropriate. The most common use of cough medicine is for suppression of non-productive cough associated with a common cold and other upper respiratory infection. So what are the drugs for cough? The drugs for cough is antitussive, or drugs that suppress cough. Some agents act within the CNS, others act peripherally. The antitussive fall into two major groups. First is the opioid antitussive and the non-opioid antitussive. Other non-opioid. Diphenhydramine is an antihistamine with the ability to suppress cough. The mechanism is unclear. Like other antihistamine, diphenhydramine has sedative and anticholinergic properties. Cough suppression is achieved only at doses that produce permanent sedation. The usual adult dosage is 25 mg every 4 hours. The opioids antitussives. All of the opioid analgesics have the ability to suppress cough. The two opioids used most often for cough suppressions are codeine and hydrocodone. Both drugs act in the CNS to elevate cough threshold. Hydrocodone is somewhat more potent than codeine and carries a greater liability for abuse. Next is the non-opioid antitussive. Dextromethorphan is the most effective over-the-counter non-opioid cough medicine and the most widely used of all cough medicines. Like the opioids, dextromethorphan acts in the CNS. Next is cold. The common cold is an acute upper respiratory infection of viral origin. Between 50% and 80% of colds are caused by the human rhinovirus, which can also cause serious infection of the lower respiratory tract. Characteristic symptoms of the common cold are rhinorrhea, nasal congestion, cough, sneezing, sore throat, hoarseness, headache, malaise, and myalgia. Fever is common in children but rare in adults. Colds are self-limited and usually benign. Persistence or worsening of symptoms suggests the development of a secondary bacterial infection. In the United States, the economic burden of the cold is estimated at more than $60 billion a year. There is no cure for cold, so treatment is purely symptomatic. Because colds are caused by viruses, there is no justification for the routine use of antibiotics. These agents are appropriate only if a bacterial co-infection arises. There is no evidence that vitamin C or zinc can prevent or cure colds, because no single drugs can relieve all symptoms of a cold. The pharmaceutical industry has formulated a vast number of cold remedies that contain a mixture of ingredients. This combination cold remedies should be reserved for patients with multiple symptoms. In addition, the combination chosen should contain only those agents that are appropriate for the symptoms at hand. Patients who require relief from just a single symptom, example rhinitis, cough, or headache, are best treated with single drug preparation.
So that would be all.
Thank you for watching!